My name is Alena Korbut, and I have Lindsay Allen as my colleague here, and we will present on the continuous glucose monitors. A little background about us: we both pharmacists, and we work for Indian population, American Indian population, basically undeserved population who has problems with diabetes. So we do use continuous glucose monitors here in our clinic, and it's a direct patient care. So our presentation is a little different than what we've heard been going on. We have nothing to disclose. So the objectives that we will cover today will describe what is continuous glucose monitors, how they work, some metrics and interpretation. Will explain how we implemented the CGMs and what inclusion-exclusion criteria we used in the study results. We also review some patient cases to show hypoglycemia and hyperglycemia detection, and we'll discuss next step of implementing our Libre 2 personal CGM. So how do they work? That's here, if you can see, there's a sensor applicator, the reader, and the sensor itself. Sensor itself is a little tiny thing, almost like a coin, that will be attached to the back of the arm that will read your read your glucose. There are differences between personal and professional devices. We've been using professional device here, and in the future it will be professional. It would be personal device, so we'll implement that. Professional device, what's the difference is it's more blinded. Patients do not see what's going on. So basically they will have their sensor attached to the back of the arm, but they cannot see what's the results, what's their sugars are running, how. And on the personal one, it's going to be different. They will have either monitor or their cell phone to check as often as they can. So how some basics of the CGM. So we have three parts of it. We have sensor, transmitter, and receiver. Sensor is a little tiny thing that will be inserted in the skin. And basically it's going to be just a little needle on the tiny sensor. And transmitter, it will be either reusable or disposable, and it will be connected to sensor that will transmit the glucose readings. And then receiver or reader, it could be either a cell phone or a little device that can be scanned to get the information. So how it works, when the CGM sensor inserted, the little needle will have glucose oxidase enzyme on the tip of this needle. It will react in the presence of glucose and interstitial fluid, and that's how it will be detected the amount of glucose in their interstitial fluid. And then it will be sent to the sensor transmitter, and it will be received either by the phone or the reader. So why CGM, or what's the benefits? Well, in 2017, it was a really exciting year for us here in Cherokee Nation. We did started using CGMs. There was not much studies going on, and so we basically kind of had to go with trial and error. But I found this meta-analysis that did kind of compare previously for use of CGM for type 1 and type 2 diabetes. So they did 15 randomized control studies, and with more than 2,400 patients, and the duration of studies was 12 to 36 weeks. And they did do the systematic review with meta-analysis of this old RCTs. And what they found that is CGM improved glycemic control by expanding time in therapeutic range, decreasing time below the therapeutic range, and time above, and also glucose variability in both in type 1 and type 2 diabetes. So really it was beneficial in both in type 1 and type 2. And that's, we also kind of figured out what happened to our patients as well. So some of the metrics and interpretation, when you have a patient on the CGM, you'll see this report that will come out. And The report will kind of show all the ranges for you to see what the target range for the patient, to kind of explain them what are we aiming for. So our, of course, target will be for glucose to be between 70 and 180. Well, it's not always easy, and patients who has uncontrolled diabetes, it's really hard. So we aim in the goal for them to be above 180 only less than 25% of the time, which is 6 hours. And we base in this based on 14 days, because the CGM will work for 14 days. Above 250, we want them to be only less than 5%, which is like an hour and 12 minutes. The most important thing, we do not want our patients to be running hypoglycemia. So if they run below 70, we do not want them to be there more than 4% of the time. And then if they are below 54, it's a problem, so we need to fix it. And of course, the goal is not to be there more than 14 minutes. The one thing here, also glucose management indicator, and it used to be, they would name it as A1C. Well, now it's kind of identical, or not identical, but approximately showing what's their A1C. And it's 9.1. Also, it will show average glucose. So based on kind of average of glucose, it will show up approximate A1C. Glucose variability is really important, and we do not want our patients to be more than 36%. And this next slide will explain why. So this next slide shows how this patient has almost like 36% variability, and what's going on with that. They are really unstable. So some of the reasons could be they have erratic diet, they either incorrectly taken their medication or missing their doses. They may consume alcohol, and we don't know this. And then they also have some variation in their activity levels. So we kind of show the patient what's going on and why is it going on like this. And we'll try to create a plan for them to be more concise, more having kind of like a plan and schedule. Okay, this time I wake up, this time I take my medicine, and this time I eat. If they are random, that's where your glucose variability comes in to play. Here we use, so when we started the program and we started using the CGM, we did not really have any tools. Well, now they created this data tool, and what it does, it kind of helps the clinician to assess the CGM data. So first they would download and look what and on the report, and then they assess safety. So the safety, like I said previously, we do not want our patients to run low blood sugar. If they are running hypoglycemia, we want to fix this first and kind of find the problem. Then we would like to see what's time in range, because that's our major thing. We want them to be majority of the time in their range goal between 70 and 180. And so then we'll concentrate on areas to improve. And here it will be either hyperglycemia or their eating patterns or taking medications, you name it. And then after that, when we agree with the patient or what it could be a possible improvement thing, we would develop the action plan. And next one, I will give it to Lindsay Allen. She'll continue on implementation.
All right, thank you, Ms. Lena. Okay, so I'm going to talk to you about implementation at our clinic. So we have a pharmacy-based intensive diabetes management clinic where we implemented this out. We see these patients who are A1C over 9 and they failed management by their primary care provider, so they send them to us to help with their care. We see them generally on a monthly basis. So when we looked at implementing CGM, we identified the utility of using a professional CGM. It was a newer technology, but we could see how it would benefit our patients. We developed a workflow for incorporating the CGM. This was a little bit challenging because initially we weren't able to expand our number of clinic days, our number of appointment slots, or our staffing. So we utilized our pharmacy resident, which was Miss Alena, to help us with this project. We proposed it to administration and got some grant funding to help move it forward. We identified our inclusion and exclusion criteria, which I'll talk to you about in just a moment. And then we submitted and got IRB approval. Some of the challenges we faced after implementation was there was some issues with the adhesive. Initially, the monitors would fall off frequently. We talked to the company and they did end up making some modifications to their adhesive and they replaced our sensors. We also had some issues with patient transportation. They had to come in once a week for a 2-week time frame when they were using the CGMs, and sometimes this was difficult for our patients. And then we had patients who the sensor would fall off and they would just discard it. So we had to implement some education for that. Our inclusion criteria for use of a CGM was essentially the same as our inclusion criteria for our IDMS or intensive diabetes management service patients, with the exception that they had to be on insulin. So it was adults 18 and older with type 2 diabetes who were on insulin and within our clinic. Other characteristics anecdotally that we found the population to be beneficial when using a CGM were those with gastroparesis, if they had a wide blood glucose variability, because then you could demonstrate to the patient where that was and identify some habits that might be contributing. Also, if we were looking to make behavior modification, and that was a challenge, we had the patient keep an activity and a food log, and then we would go through it with the day-by-day readings off of the CGM, and we could point to the patient, like, look, you exercised here, see how your glucose went down, or look, you ate a candy bar and see how your glucose went up. And also patients just that were really motivated and they wanted to have a higher time in therapeutic range. This was a useful tool for that patient population as well, because it gave them a visual representation of their sugars. As far as excluded patients, if they were pregnant or planning on becoming pregnant, they were excluded. If they had diseases that kept them from wearing the sensor, such as certain types of dialysis, critical illness, or diathermy. If they had an allergy to medical grade adhesives, if they had excessive sweating, or if they had monitor placement failure, which is what we deemed when the sensor fell off and there was less than 72 hours of data, as we weren't able to make meaningful adjustments to their therapy. For our study results, we compared the patients within our clinic before implementation of CGM to after. So for the baseline data, the patients entered our clinic with an average A1C of 10.5, and then after 3 months within our clinic, they were down to 9.8. With the implementation of the continuous glucose monitor, the average A1C started at 9.6, and we were able to bring it further down to 8.4. Now, with the implementation of the continuous glucose monitor, these patients were already enrolled in the IDMS clinic, and some of them had already been receiving therapies to get down to that 9.6, which is why we saw lower starting A1C, but then we were able to further reduce them to 8.4, so effectively decreasing some of those complications. And now we'll go through a couple of cases that just show application of the CGM and show hyper and hypoglycemia and how we impacted that. So the first case is a 56-year-old diabetic who was on Datamir 50 units twice a day. This patient did check their finger sticks, usually about once a day in the morning and then sometimes in the afternoon. This times were sporadic for the evening sugars, but as you can see, their sugars were running pretty high. We placed a CGM. The initial reading showed high. All the sugars were above range for the vast majority of the time. We were able to use this visual to discuss with the patient, make an adjustment to their insulin regimen, and then bring them back. And you can see their sugars improved quite a bit, but we still had some persistent elevations in the morning time. So this is where we might evaluate putting an aspart insulin on for this patient, or evaluating eating habits and get them further under control. But we were able to make a good impact on their sugars just in 1 week time frame. And then the second case is a 60-year-old Native American male with type 2 diabetes and multiple comorbidities. This patient was on 45 units of Datamir twice a day, 15 units of aspart 3 times a day, and Victoza 1.8 milligrams a day. As you see, they again tested their sugars, but they did have 14 days that they didn't test their sugars within this time frame of their meters. They came to us on the initial appointment. Their sugars were high. This patient also had some compliance issues. They had run out of their medications, and so we also counseled compliance with them whenever they were in our appointment. They weren't able to come back, get a CGM that day, but they did come back a week later. When they came in to get the CGM placed, they told us they had thought they might be having low blood sugars after starting back on their medications, but they weren't checking them, so we didn't know the value. So we placed the CGM and brought them back in a week. And this is what we saw. They had lows that were existing, and some of them the patient knew about and some of them they didn't. The overnight lows the patient didn't know they were even experiencing. And you can see on the Wednesday, the 31st of October, they were low 29% of the time, and that was all while they were sleeping and the patient wasn't even aware it was occurring. So that was concerning to us. We made some adjustments to their therapy, brought them back in a week. And you can see we resolved a lot of the lows. They still had one day where they were over that 4% range. That was due to some delay in change in eating habits, as what was identified based on their food log. But again, we were able to identify this issue for the patient and make adjustment within a 2-week time frame for this particular patient. So getting it controlled a lot faster than if we were relying on the patient's finger sticks that aren't throughout the entire day. And so now we're looking at implementing personal CGMs. This is the next step within our clinic. The personal CGMs do have some different features than the professional. The patient can see the results, so they don't also have to do finger sticks. And it gives real-time alarms, including when the sugars are low, high, or if the sensor stops reading. They work with your smartphone, and it gives you 14 days of data, but it does take an hour after you place it for it to start. There isn't any calibration required, and they are somewhat affordable. The cost is about the same here as for a month's worth of test strips. And so it's $70 for 2 sensors, which is about a month's worth of time frame. And some of the insurance companies are starting to pay for them, although that is a slower uptake. The inclusion criteria planned for the implementation of the personal CGMs are very similar. Type 2 diabetics within our clinic, we did indicate that they would have an A1C over 9 because our goal is to get them less than 9 to decrease the risk for complications with diabetes. We will also include those who may be between 7 and 9 but have frequent hypoglycemia. We say technology savvy, simply that means they will have to know how and be able to use the meter, otherwise it won't be beneficial for them. And they would either have to use the mobile device or have a reader to scan it. We would want them to be on multiple daily insulin injections. And then also, since we've had success with the hypoglycemia, we included those as parameters too. If they have a history of hypoglycemia, hypoglycemia unawareness, or if they come to the ER with hypoglycemia or ketoacidosis, we would include those patients. So we're working on a protocol for that, as well as chart documentation, and then we will perform staff education, identify some eligible patients, and get their consent to participate. And we'll enroll about 10 of them as a pilot study just to make sure we are seeing the benefits we expect to see with it. And then we will move forward with advancing it to the rest of our population. And so one of the things we just want to end with is, if you're looking at potentially using a CGM, they recommend with the diabetes.org website to use it regardless of what their A1C is. The patients can find benefit with it. We found it useful to use it with a food log or an exercise log as well. And that is all we have today. So thank you for joining us, and here are references if you wanted to evaluate those.